Welcome to another edition of Butterfly's POCUS Power Hour. Now, I'm Peter Weimersheimer. I'm an emergency physician, and I'm the VP of Education and Clinical Implementation at Butterfly Network. Now, we host these webinars every month to explore different aspects of point-of-care ultrasound or POCUS, from specific clinical applications to certain specialties, use, to discussion about adoption, integration, and even AI applications. And the goal is to provide content for all of you listening, which supports your journey to fully harness POCUS in your clinical practice or in your practice setting. Now, this month's session is going to be great. We have three POCUS leaders from family medicine, and they're going to discuss everything from their experiences in using POCUS clinically to how POCUS just changed the game in primary care. And also, we'll talk about some of the solutions in overcoming challenges in training and adoption. Now, we intend for these webinars to be interactive and really to be informative for you. So please use this time with our expert panelists to ask questions that are interested for you in our QA. And we'll try to get as many as we can live. And now, let me introduce you to my great colleague, Dr. Davinder Ramsingh. He's the VP of Innovation Partnerships and Clinical Development at Butterfly Network. That said, he's a cardiac anesthesiologist, and he's an amazing person and amazing at POCUS. So Davinder, great to be on another webinar with you. So why don't you introduce yourself and then start introducing our colleagues as we'll get this going. So let's have a great webinar and welcome everyone. Again, let's explore family medicine and primary care ultrasound.
Hey, Peter, so great to do this again with you. This is always fun. Looking forward to a great discussion on a very, very important topic of how POCUS can really get integrated more into primary care. I appreciate your intro. Let's just dive in to introduce our panelists. Steve, as you're the first person I see on my, Zoom panel here, if you could go forward and just introduce yourself, talk a little bit about, your background, your current practice environment, and if you could, just a little bit about what got you into point-of-care ultrasound as a primary care provider.
Sure. Thanks, Davinder. Steve Erickson. I'm family doc in Port Townsend, Washington, way at the upper left corner of your map. Been doing rural practice throughout my whole career and learned a little ultrasound even that long ago back in my residency, and always kind of did a little, but as more applications came along and handier technology came along, my use of POCUS just kind of grew with the industry. And I have just kind of steamrolled further and further into it because it solves so many problems that we all encounter in a primary care office.
Thanks, Steve.
Yeah.
Chelsea.
Hey, I'm Chelsea Forrester. I am core faculty at Hamilton Medical Center in Georgia. I am still earlier in my journey of POCUS, but have been really excited about building it throughout the early introduction with a little bit in medical school, a tiny little bit added during my residency, and then badgered my team at my institution to help get it started and get it going. So I'm just really passionate about overall how we can apply it, and just even every day getting to apply it, just like today in clinic before starting this meeting.
Chelsea, want to talk about that case? It was a case that really makes a difference in everyday life that you were able to do with the resident, correct?
Yeah, absolutely. So our case this afternoon that my co-attending, who is actually on our champion team that we're building, realized it was vaginal bleeding, and they had an ER visit a couple days prior that had a positive pregnancy test. And they're like, "Oh, this is a great one for POCUS. How about you take it?" And I was like, "Absolutely." And our resident, it was her first time getting to use POCUS, so she was really excited and so passionate. And we actually got to see an intrauterine pregnancy as our last case of the day. And we couldn't quite get some fetal heart movements or tones that we could get at that time, but we were really excited to get to see an intrauterine pregnancy with our patient today.
Yeah, and again, for everyone in the audience, part of seeing an intrauterine pregnancy is wonderful. Like that's a new life that's starting. but it's also wonderful from the medical point of view because it means that it's not an ectopic, and so much what POCUS has changed in that realm is to offload that agony of wondering whether the pregnancy that's being assessed is going to be likely viable or potentially a catastrophic uh, condition for the woman. Ben, I'll introduce you. Ben Clements is a colleague of mine from Vermont who I've known for a long time and has been really done some amazing stuff with family medicine ultrasound here. So Ben, why don't you introduce yourself and maybe talk about a recent case or maybe an epiphany case that you had that's driven your passion to go forward as you have.
Oh, there's so many of those cases. It just keeps stacking up almost every day. Hey everybody, Ben Clements. I'm a family doc. I do primary care in the University of Vermont Medical Center and also a part-time hospitalist. I'm the director of Point-of-Care Ultrasound for the Department of Family Medicine and the curricular lead for our residency program. And I got into ultrasound for two reasons. One is Peter, who really built our program at the University of Vermont. And I'll come back to him in just a second. But I'm sure all of you have had this experience of reading an X-ray and it says correlate clinically. And so as I was going through med school and early residency, I got really frustrated by reading X-rays as my way to try and figure out if this patient had pneumonia or not. And working with Peter and seeing some of his talks, I just learned the power of ultrasound. And as I started to do it in med school and then again in residency, it became more and more apparent that this would have to be part of my skill set. I didn't get much teaching beyond a couple lectures and a couple, with a couple motivated faculty. So 2 years after graduating from residency, I linked back up with Peter and did a fellowship through the ULA, Ultrasound Leadership Academy. That's kind of what put me on my track to where I am. In terms of cases, let's see, I saw a person today who I've seen a handful of times with metastatic breast cancer, and she came in with dyspnea. She also has a history of COPD and heart failure. And so we're trying to figure out, why does this person have dyspnea? And a quick ultrasound exam, just the ultrasound on one lateral point, I was able to diagnose that she had a very large pleural effusion. Diagnosis made, done.
Even the nidus for putting a needle in
Excellent.
draining. Uh, Steve, um, you mentioned it like, as you started bit in residency, there was clearly something about a smattering of the cases that you did, a smattering of the training that caught on for you. So I love if you can share some of that. And also, one of the things as we talk about in terms of providers have trained a while ago and many providers who are very comfortable with clinical exam skills, I think those of us who use this have this core understanding about there's a different diagnostic accuracy with POCUS versus just our best exam techniques that we've harnessed over years. So I wonder if you can talk about that as well.
Yeah, sure. I think there's so many examples of, exam techniques that we learned, and we cherish our careful ability to do a uh, uh, shoulder exam and do that Hawkins-Kennedy test and try to see what that means, or listen to those lungs and try and detect that fluid in the bases that would suggest someone has CHF. But boy, if you look at the sensitivity and specificity of some of these cherished exam skills, they're not that great for a lot of them. And I've told this story before, Peter, but one of the most memorable cases for me, when I had just gotten a handheld in my office and a few days later had a patient come in who was nonverbal and had a stroke, but his wife just said, he just hasn't been acting himself today. I really am concerned something's wrong. And I was kind of trying to do all of those little techniques, and his lungs sounded clear and his heart sounded okay and his belly wasn't tender and I couldn't feel this or that, and was about ready to fall back to that old geriatric fallback of, oh, maybe it's a UTI.
Check the urine.
You know, let's just, can we collect a urine cell? No, well, maybe we should just try a few days of antibiotics. But then I remembered, I've got this new toy in my office. Let me just take a quick look around. And suddenly it was just instantly clear that this person had bilateral pulmonary edema, no history of heart disease, had a real low ejection fraction, led me to go get an EKG and find out, oh, this person has had kind of a silent MI in the last 48 hours. And uh, to this day, I still kind of shudder thinking, that's somebody who very well would have gone home and died in bed with their bottle of Bactrim on the bedside table if I hadn't taken that extra minute to learn things that I just couldn't do, even with my 20 plus years of being a really good clinician. Just couldn't find out at the bedside. And that just made me a believer. And anybody who is passionate about POCUS usually can tell some stories like that.
Thanks, Steve. I mean, that's such a great storyline. And Ben, your comments about, the value of lung ultrasound. Chelsea, question for you about as you're taking on learning more and more components of POCUS, what was the initial trigger? Like, is there a lane that you kind of first said, I see the value here for the majority of my patients to learn this skill, to improve my diagnostic accuracy? Do you see POCUS as that, as a stepwise approach of saying, I'm going to learn this first and then go on to the next? And that's actually a question for all the panelists, but would love to learn just a little bit about what you decided to take on first, and then what your journey looks like as you're continuing to learn more aspects of POCUS.
Yeah, so I think if we go like way back in residency, I was like, oh, I'll try and learn musculoskeletal and like maybe lung. And it was really self-directed. We didn't have a lot of attendings kind of helping us in that area. We had the attending that was in charge of that had recently taken on a different position in a different institution. So we lost that like as soon as I got there. So I basically self-taught a few things that I thought was fun. But now that I'm a little bit more advancing in that education where I'm at right now, I like going in all at once and seeing all of them. And it's like the next step as part of that same physical exam that is answering something super, super specific from that history and the other parts of that physical. It's been really invaluable. Really easy ones that I've really been able to sell the residents on is lung. Like, it's easy. You can hit 1 to 2 spots and you're great. Like, even if you can just get one on there. I made jokes about we're so close to where the hospital and EMS are. Like, our clinic is, we can see the hospital from where our clinic is. So EMS is like joking that we could just like literally walk them over. And she was having hypoxia and I was like, grab the machine, as we call EMS. I'm like, get the butterfly. We're going to put it on at least one spot. And they're like, okay, freaking out. And so it's been really great incorporating in something as easy as lung, or not necessarily as easy, but as quick that you can grab so easily. And the residents have seemed really excited about being able to do that.
Yeah, unfortunately, I think our experience during COVID was that lung, we basically stopped even using our floor model ultrasound systems versus a handheld because of all the barriers to getting machines into quarantine rooms. And it was, an unfortunate event that a lot of people who had never even comprehended why they should do an ultrasound at all versus an x-ray versus nothing, were suddenly having these epiphanies where you'd walk into a COVID room and oops, that's a pericardial effusion, or oops, there's something completely different going on, even from COVID, that you would have never got to for hours and hours or days or second visit, that type of thing. Ben, as I guess you were at UVM through that era of a lung ultrasound, but I think we all were talking earlier about just some of the challenges of getting from 0 to, I guess, whatever speed you want to get to 100 with POCUS programs. And certainly, I've been watched your journey from a lot of bashing and a lot of struggles. And Chelsea, you're having that as well. And Stephen, you started doing something which was really kind of novel. So maybe, Ben, if you want to talk about maybe one of the really tough hindrances to doing what you're doing in a way that you were able to overcome that and start really changing the culture in family medicine at UVM in a really profound way from that effort?
I'm not sure where to even start. I mean, there were so many roadblocks that we hit early on. There was the financial issue of, can we buy the hardware? Can we buy the software? Wait a minute, our hospital already subscribes to the software. Can we use it in our department?
Thank the
Um,
emergency department.
we'll get there. Um, so those were really big, but one of the most important was, in my department, I was the first one to be interested in using ultrasound, sort of, to be interested in using ultrasound and documenting my findings and billing for it. There were a handful of people who would throw a probe on and guess at what they were seeing, not document any of their findings, not bill for it. And so that we're really trying to push away from that. But in order for me to do that, our department didn't have a process for credentialing and privileging. So for a while, I was kind of blocked from doing it until we wrote a policy, and we worked with our colleagues in the ED and made a procedure, or made a policy that made a lot of sense nationally. We've now passed it on to a few other groups of people who have taken that and run with it and do similar credentialing processes. But that was kind of the foundation. Once we had that, I was able to work towards those metrics, achieve those metrics, and then get the privileges at the hospital to be able to do ultrasound. From there, it took lots of time to get the software kind of spread out so that not just I can use it, but the rest of my residents can use it. And there's just more and more hurdles as I learn more. How do we get billing built into this? How do we It's really complicated. So one of the things that was the most helpful is to stop working in a silo. So I was trying to drive this through my department, but learned that folks in the emergency department had done this 10 years ago, 5 years ago. Folks in our hospital medicine group were doing this 2 years ago. And so we came together as a network and formed a work group that had representatives from surgery, anesthesia, family medicine, ER, hospital medicine, pediatrics, IT, and then decision makers at the VP level across the network who could really make decisions and on purchasing, on um, all sorts of issues. And from there, we really made a lot of progress.
Yeah, I
That's
think one of the things about ultrasound for everyone listening, there's an amazing community out here, and it's all specialties, and it's been driven from early adopters, recognizing that everyone has to go through the same process, that an early adopter fights battles, but even in there's so many institutions where ultrasound just is an endemic, and how do you get started, and are you successful? There are so many people in the global community of ultrasound to reach out to for support, for documentation, for different credentialing packets, whatever is needed. You don't have to reinvent the wheel yourself,
Yeah.
and part of this is that what we're supporting is better patient care. And so there's plenty of people who've had the experience who are on this webinar at how POCUS has changed patient care that are enthusiastic allies. Davinder, I'll let you.
yeah. Peter,
Sorry.
no, I was just going to jump in about, we were talking a little bit to panel before we went live about this topic. My own specialty of anesthesia, right? Share the same exact story, Ben, about how, you know, how do you go from an individual person who has interest because they had those aha events of, wow, I was able to detect this, pericardial effusion and totally change my management, or, help with, dyspnea evaluations to determine that COPD versus CHF exacerbation. Then you look out and you see, well, yeah, I did the exact same thing. Reached out to emergency medicine colleagues, saw their program, got connected to the hospital credentialing, committee, and then it branched from there. And then, it mirrors itself. To your point, I just echo everything Peter said and what you said, Ben, about how now POCUS is such a more prevalent, if you look at just medical schools across the country, how many percentage of medical schools now have an integrated point-of-care ultrasound curriculum? It's no longer, if you say POCUS to anybody in a training environment, they at least know what it is, right? Which is so great to say we're at that point now where we can leverage each other across specialties to really kind of grow and hopefully accelerate it. On that note, I do encourage everyone to continue. We got one question here, Peter. please, all of our attendees, please ask questions away. We want this to be for you to answer your questions that you have. And Steve, I'd like to direct this question for you because I know you have some unique experience with this about the question is, what is your experience with revenue in clinic using CPT codes? If you could comment a little bit
Yeah.
about how you kicked off your program and what your results were, that would be great.
I can answer that one because I presented a poster at the AAFP FMX last year on this exact subject, is our personal experience billing for POCUS in a primary care office. And the short answer was about 75% of the bills submitted were paid in full according to our insurance rates. And the ones that were rejected were for a variety of reasons, some of which with further documentation probably would have gotten covered. But I think probably the more important fact for me was, well, every time I pick up an ultrasound, I don't know if it's going to get paid or not, but if you take every single time that I did a POCUS exam, how much additional revenue did I get? You know, if you take the total revenue, but include the ones that got rejected, and it turned out to be about something, I think it was around 44, 45 bucks more for that visit for a POCUS exam that typically takes 2 or 3 minutes to do. And if you're looking at a standard 99213 or 214 visit, maybe you're getting, I don't know, 100, 200 bucks. So that extra 40 bucks is really a big, boost for an extra 2 minutes of work. And not to mention the clinical usefulness of even a negative exam of reassuring me that, okay, well, at least they don't have that, and not having to, chase our tail with a bunch of labs and tests that aren't going to be back for a while.
Yeah, I think we were talking about this earlier, but way back when, this is I think when they still had abacuses and were using smoke signals. But when I first started doing very limited 3 applications in the emergency department, and again, for everyone listening, the billing is the same. It's the same limited ultrasound CPT codes, independent of where you are as an outpatient. But was just kind of randomly doing my patient care for a year, and then went to the billing office to figure out how much I might have charged, so maybe I can get a new ultrasound system. And for I think it was aorta, gallbladder, and fast. At that time, there wasn't an EFAST, and it was over $800,000 for one person running around just doing patient care and not particularly being overly zealous. And it was a huge eye opener. Not specifically that I want to do medicine for money, but how in terms of building a program or buying equipment or having to do CME or FTE for all the things that are needed. I think has been mentioned about complexity. There's a lot of complexity in the background, and it was eye opening when that amount of building had gone through.
And I would add, Peter,
Yeah.
Particularly in family medicine, we're not really used to asking for capital budget items.
Correct.
Compared to hospitalists or surgeons or anesthesia, where no, there is a expected life of this $100,000 piece of equipment, and after 5 years, we're throwing it out and getting a new one just because that's what we do. I've still got the same stethoscope that I've been listening with for 20 years. But this does pay for itself if you're using it regularly in primary care. Insurance is reimbursing it, and that shouldn't be the tail that wags the dog, but it's important to accept that and be willing to talk about that with whoever your decision makers are that are buying you ultrasound machines.
And all of us here, and I can only assume that many of you in the audience have all gotten the answer no when you ask for things. And the idea that this, certainly in the States versus in non-fee-for-service countries, there's a different argument from health economics, but it exists. But the idea that you can have someone say, well, we're not going to buy you this piece of equipment, and yet you have an answer saying, well, in fact, I'm doing better patient care, and my patient care is actually supporting that you develop not only the equipment, but the infrastructure to do this. A really nice question here from John Martin.
Peter, can I
oh, yeah, keep
flip
going.
one thing?
Sorry. Yeah,
I just want
absolutely.
to flip this idea about billing over for a second. Here in Vermont, we're thinking a lot about cost and how much our investigations and patient assessments are costing the system. So there's one, to add billing, but two, think about what we're missing. So I did a presentation a couple months ago with our folks in urgent care. And for looking for pneumonia, for example, the chest x-ray that they order, our institution bills about $600 for that. It gets negotiated down through insurance to something like $340. But the ultrasound done at the point of care, we're billing for $129 to the patient. So significantly less cost to the patient, better test, better information done right there. Person's out the door much faster. It's hard to think of a better argument for it. And that $120 stays with me in my department, doesn't go to radiology.
And again, for those of you who are listening who are not in the US model, you can go on and on about different health economic metrics, patient care metrics, which are not involved with direct reimbursement, less downstream testing, faster time disposition, and there is now a wealth, 30 years of data, and there's some better health economic data that's come more recently. But the idea that there's a cogent argument that by picking up a probe and putting on a patient any place in the world, it makes more fiscal sense for the medical system, and it still makes more patient sense for the medical system in terms of clinical care. Really a nice question from John Martin. Each of you have likely had someone, a colleague that maybe has not embraced ultrasound as you have, and they watch you do your work, and you have a rapport with them. And what are the conversations you have with them about them maybe being slightly interested, and what excuses they have, and I think we talk about in family medicine, there's an ACGM requirement for this to be taught. It's not getting taught effectively. There's a lot of providers who have done 30 years of clinical practice without ultrasound who are asking why should they. So Chelsea, start with you, as you're an early adopter and now are training others, and just maybe go around and talk about some of your engagements with colleagues and ideas that you have about how to move the needle so that you have enthusiastic adoption by people who may not necessarily appreciate the need to adopt.
Yeah, I was really excited about this one, actually. So as I'm building a champion team with my institution right now, getting people involved has been a bit of a challenge at times, and other aspects of it have been very eager to be part of this team. For my colleagues that are not as eager, I basically just said, that's okay, and I just let them witness. Let them watch, let them see, speak the data, speak the research that's already out there that's good. And those no's have come to me as yeses without having to re-ask it. So sometimes it's not necessarily a full conversation, but a demonstration. And so much so we're running out of our seats and gonna have to request some more seats because of the level of interest in building this champion team has gone up so much. Just from demonstrating and asking to do like grand rounds at our institution. So that number is going to likely go up even further as more people see rather than just hear from those conversations. That's been basically the biggest seller for me.
Steve, you've been on both ends of the learning and the teaching. So
Yep.
what's been your experience in that regard with your colleagues?
So I would say there's a couple of barriers. One is there's no way around it. It takes time. And a lot of the things that we add to our practice, think about when you started prescribing Ozempic for obesity. You probably read a couple articles or maybe listened to a lecture, and then you were kind of ready. But ultrasound, you really have to spend some hours with your hands on a probe and getting your reps in before you're going to feel comfortable. And when you're in a busy practice, like I'm sure everybody is, that can be a heavy lift, but it's worthwhile at the other end. The other thing in terms of people kind of not recognizing is I think I certainly started from the thought of, well, do I need to scan a gallbladder? Because I can send them to radiology and they're pretty good at scanning gallbladders. And I kind of assumed that, well, maybe once in a while it would be handy to do that myself. And then I realized I do POCUS for completely different reasons than I send people to the radiology department for. I scan lungs, I scan all of these musculoskeletal things, and have suddenly a hugely more accurate and detailed understanding of why my patient's knee hurts. And I think some of that is just the knowledge needing to be diffused of what ultrasound at the bedside helps to do.
Ben, you're nodding effusively.
Yeah,
Elaborate. Keep going.
well, I think the first thing is just to reiterate what Stephen said about about the barriers to learning. It's such a big task. And I remember when we finished our credentialing packet, I just thought this is going to be impossible to take a practicing clinician and put them through 150 ultrasounds to be able to do it for real. It's such a big barrier. And we're getting through that a little bit. Um, I've had colleagues tell me, let's see, I was having a conversation with another male physician about ultrasound, and we were kind of geeking out over it. And she said, "Oh, you boys and your toys." It was like 2 years ago. Now she asks me pretty often to scan her patients when she's worried about a DVT, or she's, you know, worried about a kidney stone and that sort of stuff, or someone's knee is swollen, things that she doesn't have the skills to do right now. And I think pretty quickly people see the extra level that having ultrasound skills add. And so they're asking for help. It's not uncommon for me to see one or two extra patients of my colleagues on a typical day.
And Ben, to your point, I mean, that's a real win in the sense of how do you create that culture change, right? Because now they've at least seen the relevance of point-of-care ultrasound to improve the quality of care they can provide. Although you're assisting, hopefully that next step in the journey comes on to them taking on and motivating them to take on those training. But I think you've all commented about it takes time, right? And for us to acknowledge the fact that it does take time to support all of us to be on a journey to say, here's all the tools. You don't have to, Peter, you said it earlier, you don't have to recreate the wheel. Every year, I think we have more and more tools available for the next level clinicians to learn this. So hopefully it will get easier and easier for the new folks coming aboard and wanting to take it on. Peter, we're getting some great questions coming through here. Another question around CPT codes and billing, but related to IV services and coding for IV with the ultrasound exam. Steve, just because you're my person to ask about with coding, I don't know if you have any experience there, or Ben, if you have any insights, or Chelsea, I'd love to get your thoughts there. And then an individual talked about CPT codes. I don't want to go back through that, but if you could just link those two together, that'd be great.
Okay, specific to IVs, there is a CPT code for ultrasound-guided vascular access. And one of the basic rules is you kind of have to show that it's medically necessary. So if I've documented in my note that, due to this person having poor veins or their history of IV drug use, an ultrasound-guided IV was performed, boom, you're covered and you should get paid for the extra minute that you took using ultrasound.
I'll mention that. So there's a little nuance in IV, peripheral IVs, in that if you as a provider does it, that's a billable. If a nurse or a tech does it, it's a different nuance. But I will say frankly that, so our IV program, this is an emergency department-based program, but it's the same for outpatient medicine. Most of the IVs are put in by techs or by nurses, and they're way better than we are, frankly, at this point at doing ultrasound-guided IVs. But that's actually is a billable. So the way that works is that if you need to have a image archiving or software solution where the images are available for review. But what we do is we have our techs do the IVs, a credentialed provider, like a physician will look at the image, and what you're billing in that regard is evaluation of vein patency. So it's an ultrasound that's assessing that the vein is patent to put a catheter in. You're not billing the procedure or the ultrasound guided procedure, but it's a reimbursable procedure code as well. So in our system, every IV that gets placed by ultrasound does get reimbursed, whether it's done by a clinician or not. So the clinicians do the code that Dr. Erickson was talking about, and the non-clinicians, as long as the image gets reviewed by someone who is a licensed or is a physician or an APP, that becomes reimbursable. But it's just a little bit of nuance. But to your question of, is this feasible for a team? Absolutely. And there's lots of ways, and happy to engage offline or another on how to do that. Raymond Rowan from Ireland. Yes, you have very few providers like yourself who are POCUS enthusiasts. That said, there's so much benefit for POCUS, and so maybe Ben will reach up to you. We'll start all of three of you work with some rural catchment areas, so this is the idea is that you can argue without any question that POCUS changes clinical outcomes in patients, so again, we talk about reimbursement in the States, but the biggest reimbursement is health economics of patient care. So Ben, if you want to talk about that a little bit with some of the rural clinics you have.
I'm not can you give me a more specific question there, Peter?
Well,
I can take this one.
I guess the question is an argument. How do you put an argument forward to leadership that ultrasound actually changes is an important thing separate from reimbursement? Apologies if I didn't frame it well.
Yeah. What are some of those metrics, like, decreasing transfers to the ED is the comment that Raymond meant, or made, any additional areas that you feel like there's additional value outside of just CPT code billing?
I have not had to make an argument like that to our leadership. I feel pretty fortunate about that. The first argument was that we all have to learn this based on ACGME rules, and now ABFM rules starting in 2027. We're all going to have to be learning ultrasound in order to have ABFM certification. So that was the first thing. They know it's coming. And two, I just presented data on how much better it is than physical exam.
And Steve, you have your hand raised. You certainly practice in a rural environment, so
I can
go for it.
A good example that I have shared is I had a case a while ago of a patient who came in with kind of typical findings of a DVT, and sure enough, we did an ultrasound and they had a DVT. So we started them on treatment and problem solved. The charge for my office visit, including the ultrasound, was less than $200. And I, just to be curious, found a very similar patient that my nurse practitioner took care of a few months earlier. And as she had been taught, because she hasn't learned ultrasound yet, she said, gee, you have a DVT. We need to get you to the emergency room because that's the only place that we can get an urgent ultrasound done after hours. Because it seems like DVTs always show up at about 4:30 in the afternoon in my office. And does anybody want to make a guess what the charge was for that ED visit for a very simple diagnosis of a DVT? Because ERs are always over busy. They use order sets that the triage nurse says, gee, swollen leg, let's get a CBC, let's get a D-dimer, let's get the ultrasound, maybe even a chest CT because they didn't want to miss that PE. So the charge for my nurse practitioner's patient was $9,000 compared to making the same diagnosis and probably actually making it quicker for $200.
Yeah, and certainly, Raymond, one of the things that's been pretty interesting with data on ultrasound in resource limited areas or primary care areas is even the issue of just having to refer a patient. Right, there's an institution that we work with which had a really robust AAA program. So if a primary care provider saw a patient who met criteria for AAA, they referred to get a radiology study, for instance, but that involved travel, and it involved getting a family member to travel with the patient, and they lost 50% to follow-up. And so just by doing a AAA study in the clinic, they had nearly 100% capture versus 50% loss to follow-up. So independent of billing or anything, here's a population pool that by definition, if it's 100 patients, one of them is going to have an aneurysm that potentially can be life-threatening. And so the idea, and frankly, I work in a freestanding rural emergency department where my doing an ultrasound negates transfer for all sorts of studies. And so the idea of having that access in an area where it's difficult to go elsewhere, where the resources required downstream are they cost the system, whether it's a fee or not. And the answer to those questions is it just really changes the entire healthcare environment and it brings the patients, frankly, back into the providers who are doing those local tests.
Yeah. What do you think about that next question here about sending images to radiologists? I'd
Yeah.
love to get each one of the panelists answer there,
Sure.
because I'm sure it's been a journey right across the way here. So Chelsea, if you want to kind of go at it first, the question is, do you routinely send images to a radiologist after your evaluation for a final read to strictly use as clinical decision tool on the spot, or a mix of both?
Right now, the stage that we're at is still getting full buy-in. And so I have meetings with both cardiology and radiology to set up how we're going to do it. Our plan is not to have them overread us, but instead help with the image review and getting our champion team to feel confident in their reads. De-identified patients, things of that nature, instead of saying, hey, I want you to just make sure this is correct for the purpose. It's more of, hey, make sure I know how to capture this image and that my interpretation of this image is right, kind of type thing, not in that case. So where our plans as of right now are not necessarily to have the overread, but if we felt like we needed the radiologist, then that sounds like we need to send an actual order for a diagnostic ultrasound is our tentative plan for that.
Dan, how's that journey been going on?
I've only sent 2 ultrasounds in about 5 years for a review by somebody else. One of those was a pediatric clavicle fracture that I was not sure about my diagnosis, and I was able to march down, sorry, newborn clavicle fracture. Was able to march down to radiology and sit with a pediatric radiologist, and that was really, really informative. And the other one was a case of one of my residents who was not yet certified, did a great DVT scan. But because he wasn't credentialed, sent the patient to get a formal ultrasound through our vascular lab. Sorry, a comprehensive scan. Sorry, Peter.
Thank
Through our
you.
vascular lab, and it was read as a Baker cyst. And I disagreed with that as the person doing the QA. Called the vascular lab, got a different attending. He said, nope, you're right. That's a DVT. That's not a Baker cyst. I'll speak with the person who did it, see if they'll change the read. That was the chair of the department. Chair of the department refused to change. I thought he was being pompous, but turns out, talked to him some more, gave me some really clear explanations as to why. We had the head vascular tech weigh in. It was a big to-do. We got another scan. We got a D-dimer. It turns out it was a Baker cyst with a high D-dimer. So anyway, that one was really complicated, and it just kind of showed to me the importance of a team. But the reason why I haven't sent many scans for other people to read is I'm asking a very specific question. I'm not doing a full scan of, let's say, measuring someone's kidneys or renal resistive index or whatever. I'm just trying to answer a quick question. And if I can answer it, great. And if I cannot, I will order a comprehensive scan or whatever the next best test will be.
I'll say, Catherine, I'll hop in as well. I think one of the things, if you're establishing a program, is to establish independence. And to Ben's point, this is collaborative and it's not antagonistic with radiology, but what's happening at the clinical space is that the clinician doing the ultrasound is by the patient. It's a yes/no question. It's typically a relatively straightforward diagnostic answer, which is different from radiology, which is doing a comprehensive, more broad exploration of a certain organ or organ area. And and certainly in our system, we have an agreement that we do most of our independent reads, as Ben does. And then there's humility imaging, where any test you get, whether it's plain radiography or an ultrasound or a CT or an MRI, they all have false positives, false negatives. And the idea is that when there's uncertainty, to have the humility to ask a friend. And so we have a good relationship with our radiologists. That's taken time. It was initially not quite as good as more Antigonus, but for your question of whether you should send image to radiologists, my bias is, and I think those of us in the POCUS community, building with the independence of doing clinical decision making, the bedside with the ultrasound is going to really support growth and support development of skills. Understanding that sometimes you'll have an image which is confusing, and that's when you either order the next best test or go into the room and talk to the radiologist. And FYI, one of the things that's a benefit of having a good relationship is in our system, we've actually taught our radiology residents how to do thoracic ultrasound, because they don't do that and they don't do echo. And so it's been a little bit of a reverse pollination, where we get assistance for some of the questions we have occasionally. And in exchange, we're actually training some of their learners on how to do stuff which they actually don't do and don't understand. So it becomes a really nice shared relationship in terms of, again, the goal is patient care, and it's imaging for patient care. And what happens at the bedside is a different thing than what happens in the radiology suite. And we're very synergistic.
Great question here, Peter, about resources for independent providers to receive adequate credentialing outside of a large institution. So happy thoughts. Anyone want to jump in first on, like, any advice, especially for the family medicine specialty?
Yeah. So for a primary care provider who is not part of a large organization where you might have a credentials committee and a mentor and so forth, first thing I would do is make sure we clarify the difference between education, credentialing, and certification, because there are tons of educational resources out there. Butterfly has ScanLab and tons of online videos that you can view just in time before you go into the patient. There are other organizations that teach classes and have either online or in-person stuff. So that's the education. Once you've got the knowledge, if you don't have a credentialing board granting you privileges for what you do in your office, then you don't need to pay for a credential from some online organization. Now, you might want that just for your own kind of check-in that, okay, I do have the knowledge that is expected for someone who is doing these skills. And then the third one is some places will offer certification. In other words, if you pass our test and you send us 20 samples of your ultrasounds, we will give you a certificate saying you are certified in point-of-care ultrasound. And again, if that helps reassure you and build your confidence, by all means, it doesn't cost a whole lot of money and can be a good learning experience too.
And Steve, at the society level, I know you're involved with, workshops and opportunities there for, folks. Could you comment a little bit about that? Then,
yeah, there are private organizations, like Global Ultrasound Institute I teach for is a big one. There are, every year at AAFP, there are a series of workshops in different types of ultrasound skills. If you're a faculty, STFM has kind of a mentorship fellowship program to help guide you through that process. And Chelsea, I think you're in the midst of that right now and can probably speak more to it. So yeah, tons of opportunities out there that's only a Google search away.
Yeah, lots of different things to do. I think I did like a weekend course through a different institution that they were offering it was larger and it was a great introduction, but doing something a little bit more thorough to help build it for an entire institution was definitely what I was looking for. And I'm doing the STFM one currently. And it's a really great experience. And I'm not just saying that because somebody might be here as part of it. But I really enjoy it, and it's helping build exactly what I need to build my own skills, build the skills with my colleagues in my champion team, and build the program of the entire institution.
And want to be clear, John, that there's a very distinct difference between credentialing and hospital privileging. And so there's a lot of available online sources, places you can travel to that you can become credentialed in specific applications. But it's really important to understand what the privileging requirements are where you work. And the good news is that many places don't really have ultrasound privileging requirements. Hint, hint, Ben. And then
you can write them yourself.
Yep, you can build them yourself. So that's the idea, is that so whatever you do for training, and there's a lot of independent research for training, and there's a lot of again, there's ways you can learn a lot independently, but what you want to make sure that what you choose to do is going to satisfy your privileging requirements where you are. So the credentialing document you have should match at least the things that you need to check off the box where you work that you're allowed to do diagnostic ultrasound. And so the good news, again, is that often you write it yourself and you can set the bar kind of as low or high as you want. There's an institution we work with, which the bar is so low that you have to dig a tunnel underneath the limbo bar sitting on the ground to get there. But in general, the goal is to become competent and confident. I think that's something out of Gussie, which is one of my favorite terms that comes out of the Gussie program about confidence and confidence. But the credentialing has to match, or should match, not only you getting a good clinical skill set, but also that you can actually take those learned tools and then practice diagnostic ultrasound in your institution and be able to take care of patients independently.
I want to add one thing here, Peter.
Yeah.
The most helpful thing, I think, beyond all the independent resources, is frequency at which you revisit the skills. I've heard from so many people at my institution, through STFM, anywhere I'm doing ultrasound stuff, they pick it up, they use it, they learn a thing, they put it down, and don't revisit it for a month. And they forget how to log into the software. They forget where to put the probe. And so it's that frequency that is so important to remembering the skills.
Yep.
I think that's a great segue, as we're kind of at 5 minutes of the hour.
That's right,
so
Peter. Yep, you're right. It's
time to
closing
wind up.
time. Yeah.
But so Ben, if it's okay, we'd like to go around each of you and have you impart a few pearls for our audience. But Ben, elaborate on the concept of practice and our concept of having to not let that drop, because that does feel, again, back to credentialing, privileging, and learning, that those gaps between picking up the probe and just scanning become really a hindrance to evolution of
Yeah,
skill set.
you can learn so much through these workshops or online modules. But unless you're doing it frequently, it just doesn't stick. And so I think the most helpful thing for me was the fact that Butterfly's portable. I don't have to do it in the ER. I could take it home. And as I was learning skills through my ultrasound fellowship, my wife would find me laying on the floor in our living room, just covered in ultrasound gel, because I just kept repeating, how do I make sure I get this peristaltic along? How do I change it? And just doing it every couple days, every couple weeks, to make sure that I remember the skills that I had learned from a lecture weeks, months before. So practice on yourself, practice on your friends and family, so you're not practicing in front of the patients the first time. And the portable probes allow you to do it anywhere.
Thanks, Ben.
I could definitely
Chelsea.
echo a little bit
Yeah.
of that Ben was saying. I was cackling because that was me and my husband literally the other day, and I brought literally the butterfly home to scan him tonight so he can laugh at how much jelly I'm putting on him tonight. Because I was in the kitchen. He's like, that's an interesting place to scan. And I said, it's easy to clean. It's the kitchen floor. if I get it everywhere, it's fine. As I'm trying to get that apical 4 on myself, which was incredibly challenging. But yeah, the practice, I couldn't agree with that more. And I think something that's really important for where I'm at, especially building the champion team of my faculty and building the buy-in from my residents who haven't had the experience with it, is basically showing them that I'm doing it, showing how excited I am, and with the frequency, trying to use it as frequently as possible for my own skills and building theirs. So I couldn't agree more and just echo that.
Steve. What?
Yeah, I would agree. I travel around the country teaching ultrasound, and I have yet to come across a family doctor with spare time on their hands. So learning how to do this efficiently becomes critically important to be able to add it into your practice. And that just takes reps. I agree. Being able to take the ultrasound home and practice on your spouse rather than having to wait for a clinical indication of somebody with a need for a gallbladder ultrasound to come along. Gosh, that might be 6 weeks from now for me. And then I've sort of forgotten everything I learned in class. But being able to find a way to keep your hands on the probe. And this has been studied in several studies showing, in a general primary care practice, there are probably on average 2 patients every day who have some sort of indication to do a POCUS exam. So if you have your probe nearby, you have the login fast, you have a way to uh, archive your images quickly and document with a smart phrase that you're not gobbling up a lot of time. It really takes a couple extra minutes per day. And then that's time that you're not spending at 7 o'clock at night trying to hunt down that patient to tell them the results of their chest x-ray.
That are inconclusive.
Yeah, I guess I'll hop in as my son just started college. I've lost my last ultrasound model, and frankly, my kids initially were really excited for getting the hourly rate for point of care training, and now they're like, forget it. But to that point, I think what's really fascinating about medicine is if all of us, if you ask any medical provider when they wake up in the morning, what would like to be, they'd like to be the best clinician possible for the patients, take the best care of the patients. And we read CME, we take CME courses, we do all sorts of stuff, and yet somehow practicing ultrasound or the task of advocates have to learn ultrasound seems daunting, but it's just like anything else in medicine. If you want to become skilled at patient care, it takes that effort, and that's an ongoing, it's a lifelong learning. And the wonderful thing about ultrasound is you learn that one application, whether it's lung or it's aorta or it's MSK, and it's just like Lay's potato chips. Like you want another one, and then all of a sudden you're doing crazy stuff. But the reality is that I'll confess, in my medical training, there has been times when I've actually walked out of room, opened up a book, looked at the procedure I was going to do, shut the book, walked up in, grabbed the big needle and the scalpel, and did the procedure. And ultrasound is one of those things where you have to do it. And so you can look at the refresher on the app, right? Butterfly has that great app with those videos, and you look at it and you run in the room and you put it on and just keep on learning. And it becomes secondary and becomes rote, and it becomes a skill set that really changes lives. And so thank you all for listening and attending. And before I turn to Davinder, thank you, Chelsea and Ben and Stephen. It's just great hanging out with you. And to all of you in the audience, this is a great skill. Practice, 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 scan, 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 and just change the world. And Davinder,
Yeah,
close
no,
out. Thank you again.
I'll just very quickly say, again, thank you to all the panelists. It's worth the investment, right? I think everyone in the panel, and I think it's a great discussion. Go forward, and it's worth it. It takes time, and like anything worth, it usually does take time, but it's worth the investment. Thanks so much for sharing your stories and your insights. And for everyone out there, find your resources, find your partner, go out there and start scanning and learn the skill to make you a better clinician.
Yeah, thanks for
Thank
having
you
us.
Right.
all. Good night.